Welcome, everyone, to the University of New Mexico Law and Mental Health series, weekly discussions of practice and science featuring experts in behavioral health and the law. This is a series run by the Division of Forensic Behavioral Sciences of the University of New Mexico's Department of Psychiatry and Behavioral Sciences in support with the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenter, you can enter those in the Q&A box. And you can enter those anytime you feel comfortable, but do know that we tend to hold those questions until the end, and oftentimes it's not possible for us to get through all of them. If you are pursuing continuing medical education credits, there will be a sign-in sheet posted in the chat box as I complete this sentence. I see it posted right now, so you could go ahead and enter there. If you are pursuing APA continuing education credits, there will be a link in that same area, the chat box there, but in the latter portions of the talk near the end of the hour. So keep your eye on that chat box for the link. Bookmark, open, otherwise save that link so that you have it when the webinar is completed. And after you complete the survey, make sure you save a PDF copy of the certificate yourself. We don't have those certificates after the fact. If you missed last week's talk in the series, Dr. Jeff Kakuka's discussion of bias and death investigations through the lens of the audit of Derek Chauvin's murder trial of George Floyd is now available on our YouTube channel. The recording for this week's talk should also be available on our YouTube channel sometime later this week, and a version of PowerPoint slides for those that have registered for the series will also be available later this week as well. As a heads up, we will be taking 2 weeks off for this law and mental health series as the UNM Forensic Postdoc wraps up. We will be returning the first week of September 2nd, with Abby Muley and Jared Ruchensky, who will be discussing dimensional perspectives of psychopathology assessment in forensic settings. But circling back to this week, I'm very excited and honored to introduce you to today's speaker, who will be discussing vicarious trauma in forensic mental health professionals. This is Dr. Maeve Cardwell. Dr. Cardwell is a forensic psychology postdoctoral fellow here at the University of New Mexico School of Medicine, where she conducts competency to stand trial evaluations and is heavily involved in New Mexico policy development. She earned her bachelor's degree in psychology from Creighton University and worked as a behavioral tech on an inpatient psychiatric unit for adolescents before returning to school to pursue her doctorate. She completed her PsyD from William James College in clinical psychology with a specialization in forensic psychology. Dr. Cardwell has worked with adolescents, traditionally aged youth, and adults in academic, outpatient, inpatient, and correctional settings, and plans to continue working with individuals with forensic involvement. I'll add that through this year, I have come to know Dr. Cardwell as a great colleague, a mindful colleague, and someone who I've also been able to see put these issues of managing vicarious trauma and professional distress into practice. So Dr. Cardwell, Maeve, on behalf of your institution, we're thrilled to have you joining the series formally and sharing your expertise with all of us today. I will go ahead and toss it over to you.
Thanks so much, Anthony. Good morning, everybody. As Dr. Perillo said, my name is Maeve Cardwell, and I'm going to be speaking to you about vicarious trauma in forensic professionals. All right, some information on continuing education credits for folks. This will be included in the PDFs that'll be sent out afterwards. And before we begin, I do just want to make it clear that I do not have any financial arrangements related to this topic. There's no financial benefit that I'm getting as a result of discussing this topic. There's been no financial incentive to present on this topic. I would also like to make clear that the views expressed in this presentation are my views and do not necessarily represent the views, policies, or positions of the University of New Mexico. And finally, some learning objectives that I'm hoping everyone will feel comfortable with walking away today. The first being that I hope people feel comfortable identifying resilience and risk factors related to vicarious trauma in forensic professionals. I'm also hoping that people will be able to describe differences in conceptualizing vicarious trauma and burnout, a similar construct, including how we treat them differently. And finally, I'm hoping that people will be able to assess for ways identifying vicarious trauma in themselves and in others, including implications for intervention and support. So first things first, what is vicarious trauma? I'll be shortening vicarious trauma to VT throughout the presentation just because it is very long term. But vicarious traumatization or vicarious trauma is a term that's based in constructionist self-development theory and was first used in 1990 by McCann and Perlman. The phenomenon that they termed vicarious traumatization can be understood as how the graphic and painful material that trauma clients often present with can interact with and impact a therapist's unique cognitive schemas or beliefs, expectations, and assumptions about themselves, others, and the world. McCann and Perlman's primary theory was that trauma discussed by clients can disrupt the existing schema of the therapists who are providing care. Additionally, the unique way that trauma is experienced by those clinicians depends in part upon which schema are central or salient for that individual clinician. The severity of the discrepancy between the clinician's existing schema and the client's traumatic events influence whether the changes in clinician schema are subtle or more obvious. McCann and Perlman also discussed the impact of working with trauma survivors on memory of the clinician as well as their cognition. McCann and Perlman cite research indicating that therapists who serve in this role may internalize and experience memories discussed by their clients. They explain that this effect can be temporary or permanent and may impact the professional and personal functioning of those clinicians. Although clinicians have not personally experienced the exact events discussed by their clients, they may experience vivid memories, dreams, or flashbacks that feel as if the clinicians have experienced those events. McCann and Perlman believed that the images most impactful for clinicians are those related, again, to the clinician's most salient need areas. So as an example, someone for whom safety is really important, is a salient need in their life, would be expected to be most impacted by trauma disclosures related to a lack of safety. McCann and Perlman emphasized the importance of the helper or clinician being able to acknowledge, express, and work through these painful experiences, with specific mention of the necessity of a supportive environment in which to do so. They identified effects of untreated vicarious trauma as including feeling numb or emotionally distant, which would negatively impact the clinician's ability to interact effectively and empathetically with their clients. More recently, an examination of the psychometric properties of the vicarious trauma scale supported McCann and Perlman's conceptualization regarding the cognitive aspects of vicarious trauma and added that there is an indication of affective symptoms as well, both physical arousal and avoidance behaviors. All right, so I did not personally conduct any research related to vicarious trauma. This is more of a literature review of kind of what's out there, the studies that have been conducted by other researchers. And the first study that I would like to talk to you about utilized forensic interviewers as participants and spoke to a few shared characteristics that these forensic interviewers noted as effects of their work. So the participants in this study were all forensic interviewers, mostly social workers, who interviewed children who had either been the victims of a crime or had witnessed one. The authors of the study conducted interviews with these professionals, focusing on the unique experience of each professional over large numbers of participants. As such, they sent invitations to participate to 12 interviewers who were working full-time in this profession, I believe in the state of California. I could be mistaken about that. And 9 of the clinicians that they invited to participate agreed to do so. The first category that I'd like to talk to you about were triggers that participants identified as triggering the vicarious trauma symptoms, things that they experienced in their work. So the first trigger that they identified was graphic descriptions of crimes. Of course, the more detail that the interviewer gets, the better an idea they're going to have what happened. Of course, any kind of crime perpetrated against someone could be a traumatic event. And if it's a very clear description, that can contribute to more of an understanding on the clinician's part of the minutia related to that event. Severe trauma was also identified as a trigger, those really extreme cases, particularly if children were the victims in these situations. Thirdly, they identified tentative disclosures as a trigger. For those of you who either have worked with children or who are familiar with the literature on working with children, there's a pretty general consensus that children don't disclose everything all at once, right? Children tend to disclose things in kind of a piecemeal fashion, as if they're testing the waters, trying to see, can I trust you? Will you believe me? Are you someone who's going to advocate for me, or are you going to make me feel bad about what has happened? Um, so tentative disclosing is a component of, or a stage of that process that is generally seen with children who are disclosing having experienced abuse. Particularly, these participants discussed feeling as if they had to push the children that they were interviewing to open up to them to enable them to get the information they needed. One participant reported feeling like they had to turn off their humanness and sacrifice themselves in order to get the information that they needed from a child who didn't want to fully disclose what had transpired. Emotional responses were also identified as a trigger, both emotional responses from the interviewee and from the interviewers. Regarding the emotional responses of the interviewees, the children, body language was cited as an indicator of distress that the children were experiencing, which could be really triggering for the interviewer. Examples included children rocking in their seats, sitting in the fetal position, or having their heads down on the interview table while the interview is being conducted. Regarding the emotional responses of the interviewers, an inability to express the emotions that they were feeling, or a need to keep everything kind of shoved down in order to maintain professionalism and collect the data that they recognized as being important to their work, were cited as experiences that were kind of shared among participants. It's unclear whether these feelings were ever processed by the participants that disclosed them, or if they just kind of tried to move on with their lives and never took the time to go back, address those feelings, process them, and really try to manage them in an effective way. There's a quote here from the study that I thought was really, really descriptive and a good kind of summation of these 2 points. One participant noted, "It is vital to this child's welfare for me to get what I need. And maybe that's what overrides my desire to not react in shock, but, show empathy in that moment." And I never get to show the empathy, actually, as I'm thinking out loud. I never get to show that. I get what I get what I need, and then we're done, and I never see him again, him being the child that was being interviewed. Participants also identified graphic images of trauma as triggering, photographs in particular. I actually had a conversation with a colleague about this a couple of weeks ago. We were discussing reviewing collateral information within the context of a whole variety of forensic evaluations, not necessarily interviewing children specifically. But my colleague mentioned an experience of having been going through collateral information and kind of stumbling across photographs of injuries that had been sustained during the commission of a crime and being shocked, one, by the nature of the photographs, but two, just by their presence, not having had any warning that they were there. So kind of consistent with this trigger of graphic images, that feeling of surprise and maybe not having enough warning to be able to prepare yourself to see what you're going to see. Finally, system failures were identified as a trigger for these feelings of vicarious trauma. System failures both of the children that were being interviewed and of the interviewers. So particularly the interviewers discussed feeling isolated and unable to turn to other people for support. One participant discussed the experience of being the only person physically in their office during a late night interview, and highlighted the impact of that literal isolation as it relates to this kind of work. Another participant discussed feeling emotionally isolated because of their need to protect everybody from what they're walking around with, that the severity of the things that they've heard, the distressing nature of what has been disclosed to them. Also discussed were the ways in which the system has failed these children that are being interviewed, particularly children who are returning to be re-interviewed after having experienced or witnessed more abuse, more crimes. The participants in the study discussed the effects of this on their own feelings of guilt, because as part of this system, they felt as though they had failed these children and allowed these children to return to an abusive environment. In addition to triggers, the participants identified a few instances of cognitive dissonance, which contributed to this experience of vicarious trauma that they were discussing. The interviewers discussed the effect of having to sit calmly and listen while children revealed these terrible abuses that they had been through. Some participants explained that they were confused by their own ability to sit calmly and to intellectualize these experiences, particularly when they had strong emotional reactions to the reports that were being given to them, or if they had backgrounds that were focused on trying to make change in clients' lives. They had a therapeutic background. So particularly for anyone who has that history of a more treatment-oriented background as opposed to an assessment-related one or more of a research background, that confusion of how am I able to sit and listen to this information without engaging in those more comforting techniques that I've been trained to use. Finally, interviewers discussed how this cognitive dissonance impacted their attempt to achieve syncretism. That was a new term to me. I don't know if others are familiar with it, but the researchers described syncretism or defined syncretism as the process of achieving complete self-realization and building a social structure in which the physical, mental, and spiritual needs of all people can be met. For the children who were experiencing repeated abuse, this effect highlighted, for the clinicians, these children experiencing repeated abuse highlighted the ways in which the system that they reside in and that they function in doesn't have a social structure which meets the physical and emotional need for safety of these children. This experience also, in the clinician's perception, decreased the credibility of the interviewer in the child's eyes. The interviewers also discussed feelings of derealization following the interviews that they performed while still at work, and some identified not experiencing feelings of vicarious trauma until they had left work and returned home. So, and in a kind of highlighting that discrepancy with the syncretism they were trying to achieve, not having a social structure in place that is allowing them to process what they need to within the environment in which it happens, and in fact, taking those effects home with them and having that impact other aspects of their lives. All right, as a continuation, the researchers noticed some commonalities among coping responses of the participants. So one such coping response was shifting within the interview setting. The interviewers described shifting as increasing their ability to take in information by becoming disengaged and more technical, and by intellectualizing the trauma. This includes reported efforts to hide physical responses to the descriptions of trauma. One participant reported sitting on his or her hands so that the child they were interviewing wouldn't see that the interviewer's hands were shaken. Interviewers also reported or described shifting rather as into either an engaged mode in which there was more attempt to engage on a cognitive level, or to a disengaged mode in which interviewers shifted in order to try to modulate their emotionality related to the traumatic topic that was being discussed. A second coping response that was identified was an attempt to become hyper competent, or a focus on becoming the best in their field. This, on the other side of the coin, also served to try to hide a clinician or interviewer's struggles from their peers and colleagues. This, of course, can kind of become a self-fulfilling prophecy that's not entirely helpful when these interviewers are being recognized for the work that they're doing, for being the best in their field, and having that positive reinforcement of someone within their organization or another colleague praising them for that without having that understanding that this is the person sacrificing, processing their emotions, and instead shifting focus elsewhere to something that's more within their control and feels less daunting to try to manage. The third coping skill that was identified, or coping response that was identified, were high risk behaviors. These behaviors included misuse of substances to either distract or dull the response to the interviews, risky sexual behaviors such as sex with strangers or unprotected sex, and extreme sports such as skydiving, base jumping, that sort of thing. A second study that I looked at was a literature review of studies evaluating secondary traumatic stress in criminal justice professionals more broadly. Secondary traumatic stress is an umbrella term that was used to describe the effects of both burnout and vicarious trauma. Participants in this study included law enforcement and correctional officers, judges, attorneys, and anyone who had worked with offenders or victims in any setting. There were a few risk factors for vicarious trauma that were identified as results of this study, of this meta-analysis literature review. One risk factor was feelings of helplessness or horror related to what these professionals were being exposed to. So, for example, reports of trauma from children were likely to have a more extreme response from the participants based on the distress of knowing that children were subjected to such treatment. A personal history of trauma or psychological distress was also identified as a risk factor. So if one of these law enforcement officers, judges, attorneys, or clinicians had personally experienced trauma, they were at an increased risk for experiencing symptoms of vicarious trauma. They were also at an increased risk if they had experienced symptoms of depression or anxiety, which is what is meant by psychological distress here. A third risk factor were the use of maladaptive coping skills. So if someone tended to engage in really any of the coping mechanisms that we saw on the last slide, such as substance use disorder, risky sexual behaviors, that adrenaline-seeking type of behavior, those things were all identified as risk factors. And finally, a lack of social support, lack of ability or comfort with turning to others, whether that's because the professional really doesn't have anyone that they can turn to, or they just feel the need to kind of keep those disclosures or those experiences that they have had, or the trauma that they've been have had revealed to them, kind of compressed, kept inside, rather than sharing it with those around them. There were also protective factors that were identified in the literature review. The first being compassion satisfaction. So I'm assuming everyone here, or the vast majority of folks here, are familiar with compassion fatigue, kind of that feeling of becoming overwhelmed, tired, fatigued, due to that pull on our emotional resources. Compassion satisfaction is kind of the flip side of that. It was defined by the authors of this study as the pleasure one receives from being able to help and accomplish their professional responsibilities effectively. So that acknowledgement of my work is making a difference. What I'm doing is helping people, right? Has been shown to be a protective factor, or is believed to be a protective factor for vicarious trauma symptoms. Adaptive coping strategies were also identified as a protective factor. This makes a lot of sense, right? It supports that ability to process any trauma that these folks might be exposed to, a healthier way of processing those experiences. And as examples, exercise and spiritual coping were identified by the authors of the study. Third protective factor that was identified were organizational and personal social supports. So that organizational support piece is particularly important in reducing feelings of burnout and improving work environments. Going back to the compassion satisfaction bullet point, that recognition from organizational members can kind of increase that compassion satisfaction or contribute to those feelings of compassion satisfaction. Additionally, social supports outside of the organization mediate the effects of stressors, decreasing the amount of distress felt by the respondents in these studies. Right. This study also yielded information that the literature they reviewed, the studies they were looking at, had reported low to moderate levels of secondary trauma among the participants, those criminal justice professionals. And there were a couple of theories as to why that might be included below. The qualitative data from this literature review indicated that many of the participants in these various studies had been unfamiliar with the concept of secondary trauma prior to their involvement in these studies, which may have impacted their recognition and subsequent reporting of secondary trauma symptoms. Another theory was that there was a stigma within law enforcement of acknowledging the symptoms that they were experiencing. The theory was that law enforcement personnel overreported positive behaviors and descriptions of their work in order to be perceived favorably. The authors cited the culture of law enforcement being reluctant to identify symptoms of psychological distress. They didn't really go into too much detail beyond that, but for my own part, I would assume that this is supported by concerns of officers either being put on desk duty or being removed from the work that they would like to be doing if their higher ups were aware that they were having psychological distress, and potentially trying to hide those effects in order to prevent a change in their job responsibilities that they may feel a lot of pride for being involved in. The authors also hypothesized that participants may have been covering symptoms with substances. They may have been self-medicating, which may have impacted their recognition of the symptoms they were experiencing, as one of the possible explanations. Finally, the authors suggested that the reported rates of secondary trauma may have been more strongly influenced by burnout than by vicarious trauma itself. They reported that this seems to be a likely level of some influence, particularly in a system that is under-resourced and understaffed. All right, the third study that I looked at was a meta-analysis of 27 studies, which provided information on key aspects of vicarious trauma intervention for service providers working with people who had experienced trauma. The types of trauma experienced by the clients of these service providers was varied. Medical trauma, trauma resulting from war, natural disasters, and violence were all represented. Vicarious trauma-related outcomes were most commonly measured with the ProQual-5, which includes compassion fatigue scale, a burnout scale, and a secondary traumatic stress scale. The compassion fatigue self-test and secondary traumatic stress scale were also used by studies to assess symptom presentation. Literature on the vicarious trauma interventions mostly targeted healthcare professionals, while the rest of the literature targeted human service providers serving clients exposed to violence, abuse, and disaster. So that vicarious trauma side kind of focusing more on the healthcare professionals, whereas interventions and literature relating to maybe compassion fatigue and burnout more oriented towards those clinicians serving populations who had experienced violence, abuse, and disaster. There were three primary types of treatment that were evaluated: psychoeducation, mindfulness, and art and recreation. Just as a note, the meta-analysis indicated that there was some overlap between like the operationalization of psychoeducation and mindfulness. So the results weren't entirely clear, but they were clear enough for the authors to feel comfortable speaking to. So just something to keep in mind. For the psychoeducation intervention, it was reported as having shown promise regarding the treatment of vicarious trauma, secondary traumatic stress, compassion fatigue, burnout, and other negative psychological symptoms such as anxiety. Some of the studies that were reviewed reported mixed results, however. For example, a resilience intervention for healthcare workers showed a positive change in compassion satisfaction, which, as we know, research has shown can be a protective factor against the effects of vicarious trauma, and a small reduction in burnout. However, no change in secondary traumatic stress was identified during the pre and post follow up. A review of the mindfulness interventions demonstrated their effects on vicarious trauma symptoms and outcomes related to mind body wellness, such as somatic symptoms and insomnia. However, the format in which mindfulness training occurred seemed to impact the longevity of the effects. For example, a retreat based intervention showed positive effects of reduced vicarious trauma, which lasted until the 3-month follow up, but the effects were no longer seen by the 6-month follow up. In contrast, a smartphone based mindfulness training showed similar or better effects of reduced vicarious trauma compared to traditional in person training formats. Now, again, they didn't go into too much detail about the specifics of the smartphone-based mindfulness training, but it seems to me that this result makes sense given that presumably if the participants had continuous access to that smartphone-based mindfulness training, they may be able to continue reinforcing those habits whenever they need to, as opposed to with that retreat-based intervention, only having exposure to those skills for a few days, a few hours, however long the retreat may have lasted, and trying to rely on their memory moving forward in order to appropriately utilize those interventions. Finally, the art and recreation intervention. Overall, art and recreation interventions resulted in participant reports of increased positive emotions and positive coping, improved interpersonal relationships and sense of belonging, and improvement in their work. These interventions also reportedly reduced participant stress, anxiety, and depression. There were 2 particular interventions that were discussed that stuck out. One was a poetry-based intervention in which participants were asked to read poetry and then engage in a writing exercise of their own, which allowed them to express emotions in a nonverbal format and a written format, which likely changed the way that they interacted with those experiences. A second intervention that was discussed was a music therapy group, or rather a drumming group more specifically, which was run by a clinician who had experienced drumming and was in a group format, allowing for participants to have this experience of peer support, peer interaction, while also, again, being able to express that emotionality in a nonverbal way and just kind of get those emotions out. Overall, the vicarious trauma intervention showed promising outcomes for not just the primary symptoms of vicarious trauma, but also secondary symptoms such as self-efficacy, job satisfaction, and mindfulness. Specifically, the qualitative studies reviewed here indicated common reports of more mindful awareness, less self-criticism, greater relaxation, an increased sense of belonging, and an escape from vicarious trauma. The review findings indicated that vicarious trauma interventions were effective in decreasing some vicarious trauma-related symptoms, but not all. These results were interpreted to mean that the treatment of vicarious trauma symptoms may need to be tailored specifically to the symptoms of concern rather than taking kind of a global generalized approach. Furthermore, interventions delivered over a longer period of time may need, Furthermore, interventions delivered over a longer period of time and in group settings may help decrease vicarious trauma symptoms by providing peer support as well as targeting the symptoms directly. Now on to burnout. I did mention earlier that we were going to talk a little bit about burnout. So I want to make sure that everyone's kind of familiar with the conceptualization as I'm utilizing it. The term burnout was first used in the 1970s but versions of this concept were discussed earlier than that. There were three key dimensions that were identified in the literature that I reviewed as contributing to burnout. The first of which is feeling overwhelmed or exhausted. This exhaustion dimension has also been described as wearing out, loss of energy, depletion, debilitation, and fatigue. The second key dimension was a cynicism and detachment. The cynicism dimension was originally called depersonalization, given the nature of human services occupations in which this term was first developed, but has also been described as negative or inappropriate attitudes, detached concern, irritability, loss of idealism, and withdrawal. The third key dimension that was identified was a sense of ineffectiveness or a lack of accomplishment. The inefficacy dimension was originally called reduced personal accomplishment and has also been described as reduced productivity or capability, low morale, and an inability to cope. So treatment of burnout, right? That's an important component of this. We want to make sure that folks are getting the interventions that they need in order to manage these symptoms. So in 2001, Maslach et al. Hypothesized that a combination of systemic change and personal interventions would be most effective for treating burnout. While systemic change is helpful, it is harder to initiate than personal interventions. And I would say this is particularly true in forensic professions, particularly when there is no change in the demand on our time and our resources. If anything, there may be an increase in that demand, but if there is no increase in the service providers to meet that demand, it's difficult for the system to try to reduce the burden or reduce the demand on clinicians, folks who are providing interventions without something else to take that place. Regarding effective interventions, mindfulness training, peer support, cognitive behavioral techniques, and emotion regulation have all been offered as effective interventions for burnout. Structured debriefings, particularly after emotionally charged or high stress cases, have also been identified as an effective intervention because they provide an environment in which to process emotional responses and have been shown to bolster emotional resilience and promote well-being. Systemic interventions could include improving supports and recognition for the jobs forensic professionals are doing and would include appropriate compensation as well. So these interventions that we want to focus on are resilience training, stress management, peer support, and appropriate compensation. Regarding those systemic interventions, the mention of recognition for forensic professionals, again, going back to that compassion satisfaction prong that we talked about a little bit earlier, recognition for the work that is being done, for the difference that is being made, and particularly for the difficulty that may come along with, or the distress that may cause in professionals. Finally, for appropriate compensation, this is referring to both time and pay. Of course, we need to be able to make ends meet to pay our bills, support our families, pay our student loans. But if an increase in demand is being made of clinicians, but there's no increase in time within which to meet these demands, that is, of course, going to contribute to symptoms of burnout as well. All right, so as discussed earlier, one of the learning points for this presentation was to be able to distinguish between vicarious trauma or burnout. So to simplify that a little bit, we have a summation slide here. Vicarious trauma, according to the literature that I've reviewed that we've discussed today, those symptoms are more in line with trauma symptoms, right? The challenging of cognitive schema, the affective symptoms, whether that's avoidance symptoms or physical arousal, and also the imagery that clinicians have experienced, even if those events that they're remembering are not events that they personally experienced. Things like flashbacks, nightmares, those sorts of things. As such, the focus is more of the traumatic event that was experienced by others as opposed to another cause. Whereas with burnout, the symptoms that we see tend to be more in line with depression symptoms, those feelings of detachment, overwhelm, kind of a difficulty engaging. And the focus is the job that people are doing, right? Those chronic job stressors have been flagged as causes of burnout, things like too much demand without kind of a balance of resources. And as far as the treatment side of this goes, vicarious trauma is likely to be most effectively treated by engagement in group activities that encourage expression of some sort, whether that's an emotional or a physical outlet. Research indicates that feelings of isolation are a significant contributing factor to vicarious trauma. So, engaging in activities that foster a sense of support, community, belonging would all be expected to reduce this effect. Additionally, processing the difficult emotions or feelings of trauma rather than numbing them or repressing them is likely to help to prevent them from becoming overwhelming. For burnout, stress management techniques have been shown to help reduce feelings of burnout. Learning to set boundaries where possible is also helpful in preventing someone from becoming overwhelmed or feeling compelled to sacrifice quality of their work in favor of meeting deadlines. As as I mentioned here, where possible is a big key component of this. We can't always choose what we take on. Sometimes there's something that needs to be done, and we're the clinician that's available to do it. You don't really have a choice. But I think for a lot of us, particularly as an early career professional, we're very eager to take on new experiences, become more proficient, or even just get exposure to a new type of evaluation or a new type of intervention. And that's not always something that's feasible in the moment for us with all of the other things that we have on our plate from a professional standpoint. So recognizing that, hey, I'm kind of at my limit here. Maybe I should take this one on later, or maybe this is something that I can try again in the future at some point, or even just I don't have the bandwidth for this right now. And then mindfulness has indications of being effective for both presentations. Overall, broader structural issues may complicate managing these experiences. Burnout is a possibility no matter what environment you work in, and there is such a need for healthcare access that clinicians are, not surprisingly, asked to take on large caseloads to meet demand. These requests, however, are not always balanced with appropriate compensation, whether that is financial or temporal, to support the increased work output. This can also contribute to vicarious trauma if the population you work with is likely to discuss traumatic events, such as we see with forensic populations. Increased work demand from systems in which we work can reduce the amount of time we have to engage in self-care, stress management, and processing of emotions, especially when there are outside responsibilities also demanding our resources. With this in mind, making efforts to stay connected with personal social supports and professional ones can help reduce feelings of isolation and may even reveal supports that were not widely publicized. So, for instance, if your organization has access to resources, to mental health resources, or is able to support weekly, monthly group outings that facilitate a connection with peers and colleagues within the same office, those sorts of things would be helpful and may not be publicized widely, but may be revealed and shared amongst colleagues. If one person knows and someone else makes contact with that person, that information is shared with them and it can be disseminated on a broader scale. This can also be accomplished by coordinating peer support groups, whether informal or supported by your employer, or simply checking in with coworkers, particularly if those coworkers have given indication of feeling overwhelmed or disengaged. Right? If you have a coworker who you see is engaging less with others, who seems to be frazzled all the time, who seems like they've got too much on their plate, and is having difficulty managing all of it, connecting with that person and trying to help at least facilitate those social supports where possible, or make recommendations for other other interventions could be helpful as well. And that is all I have for you. That went a lot quicker than in my practice.
Well, thank you so much for all of that information, Dr. Cardwell. Maeve, for the background and different concepts related to vicarious trauma, secondary trauma, burnout, and perhaps some considerations of what we as individuals could do should we experience this in our practice. Dr. Cardwell has put up the QR code there on the screen. Shortly, there will be, or actually right now, is the link for the CEU survey for APA, continuing education credit. So that is in the chat box now. We do have a number of questions already here, but feel free to add more. We'll ask Maeve here a couple of questions here from the attendees now. So going back just to clarify some of the concepts that you discussed earlier, someone asked if you could give a reminder of the difference between vicarious trauma and secondary trauma, if there really is a difference at all.
Absolutely. So, according to the research that I looked at, that secondary traumatic stress or secondary trauma term was kind of used to incorporate vicarious trauma and burnout together. So, the research seems to indicate, not surprisingly, that there's a lot of overlap between the two. I think, particularly for people experiencing vicarious trauma symptoms, they may be more inclined to experience that burnout as well, the feelings of being overwhelmed, having too much that they need to do, trying to manage everything effectively, and feeling disconnected from the work that they're doing. That also, I would think, probably goes the other way. If someone's feeling burnt out by the amount of work that they have to do and then is engaging with a client who is discussing a traumatic experience, if they're already not utilizing adaptive coping mechanisms for the stress they're experiencing, maladaptive coping mechanisms was identified as a risk factor for vicarious trauma, may increase that risk of experiencing the vicarious trauma as well. Again, I have not done research on this topic, so these are all just theories coming from me, but that secondary traumatic stress term was used to incorporate both vicarious trauma and burnout together.
Somebody referenced earlier that they were interested in the idea that people engage in extreme sports as a reaction to vicarious trauma. Is this considered a maladaptive response like other risky behaviors, like risky sex? Or is extreme sports more defined by risk of death or just the idea of pushing one's body physically, like exercising in a gym?
That is a very good question. The authors of that article did include it within those risky coping mechanisms. My assumption is that the risk of death is at least partly a component of that. I would also think that it may be kind of an avoidance mechanism instead of processing the emotions that the person is experiencing that are causing this level of distress. They may be trying to essentially run from or use adrenaline as a way to kind of almost self-medicate and kind of cope with these feelings or ignore these feelings rather than coping with them.
We've gotten a couple of questions related to, I think this is in reference to a lot of people's experience, at least beginning 5 years ago with remote work. And well, somebody asked if you came across any differences for remote forensic professionals versus those who continue to work in person or on site.
Ooh, that is a good question. None of the studies that I looked at addressed that actually. But with that being mentioned, I'd be interested to see what difference, if any, exists.
Sure. Yeah, and I know that a couple of years ago, we had Mia Ricardo come on to talk more about the burnout perspective from remote working, particularly in the competency crisis during the MITS pandemic. Less so the vicarious trauma issue, but more of the burnout, depressive symptoms that you had referenced before. Somebody also asked similarly, do you have any recommendations for how to unite colleagues who are doing forensic work virtually for a sense of community?
Oh, I hadn't thought about that. I love that idea. I would think maybe, an environment like this, if there's like a listserv or something that can be utilized effectively, maybe once a quarter, once a year, having sort of an environment like this that's all of these people are interested in forensic work, and maybe they just have the option to hop on Zoom and have lunch together, meet if they want to. I know there's been for postdoctoral fellows within forensic psych, there's been an environment like that that my co-fellow and I have attended a couple of times this year that has been really eye-opening. It's been interesting to see some of the shared experiences at like this level of our profession. And I imagine that something like that might be interesting, particularly for more established professionals who are a little further out of school, don't necessarily have that same connection to other students or new graduates that we do.
Somebody asked about their wonder of how racial identity of the evaluator may be a mediating factor for a lot of these issues of vicarious trauma. They wrote, for example, shifting is an old concept in communities of color and as a form of being and coping in spaces. There's a famous book on shifting, The Double Lives of Black Women. Do you believe the convergence of the management of daily threats to one's person and safety may mean that evaluators of color are unfortunately already coming in more equipped to manage these spaces?
That's a great question. Again, that's not something that was referenced in the literature that I looked at, but it wouldn't surprise me if that's the case, particularly coming from a demographic that maybe is exposed to more trauma or more threat of any level. I would expect that people who belong to that demographic may come in more equipped to handle those type of experiences. But again, not something I came across.
Someone asked if any of the research you came across touched on how the emotional reactivity of the interviewee affected the experience of vicarious trauma of the interviewer, basically the presentation of the person that you're examining.
Sure. I, at least in that first study that I discussed with the forensic interviewers who are working with children, that was identified as a trigger for them. And I don't know if that was maybe more impactful because they were children, that these were children that they were working with. And of course, children are a vulnerable population. I think a lot of us, especially in a helper field, want to protect everybody, but particularly children. That was identified as something that could trigger those experiences of vicarious trauma. And I would assume that that is true to some degree for adults as well. If there is, someone who either as maybe a defendant going through an evaluation or as a victim going through an evaluation, someone who's having what is perceived as a genuine emotional response, I would think that that would increase kind of the severity or perceived severity of what they've experienced. And severe trauma was also identified as a trigger for the forensic interviewers in that first study that we talked about. So to answer that question simply, yeah, I would expect so.
Sure. And as you referenced, there are traumatic events that are directly or indirectly experienced by others. There are arguably some forensic evaluations that inherently might expose people to more hearing about or seeing traumatic events relative to others. Somebody asks particularly about doing evaluations of individuals accused of crimes related to child exploitation materials, child pornography issues, that they said they're often amazed that there's a list of scenes that were on the person's electronic device, that someone in a legal position had to view these scenes.
Mhm.
Is there a way that vicarious trauma can be addressed among those professionals in particular, or any unique considerations? Perhaps somebody that's going to be, as an inherent part of their job, continually being exposed to things that most of us would find quite distressing.
Mhm. I would think being aware of the nature of what they're going to view would be helpful ahead of time if possible. Again, kind of going back to that graphic images trigger that we discussed and the conversation I had with my colleague recently. If it's something that the person can prepare themselves for, I would think they might be a little bit better equipped than if it's a surprise, like, if someone's reviewing maybe evidentiary photographs, and there is something much more severe than what they've viewed up to that point that just kind of pops up out of nowhere. I think if there's a way to have that kind of be indicated ahead of time as far as like, hey, like prepare yourself, that would probably be helpful. I can also imagine that particularly for those folks having a good balance of work and personal life, right? Making sure that they are taking time to actually process the experiences that they're having. I mean, a lot of my background is in conducting individual therapy. I would argue that those folks should have a therapist. They should have someone that they can talk to and communicate with, or at least have effective social supports, people that they can rely on when they're having, a difficult, distressing moment. And even if they're not discussing what they viewed with those people, just knowing, hey, there's someone here to support me, who I can turn to when I'm not feeling good, or I can go do an arts class with, I can go work out with, I can do something that has been identified as an effective stress management technique. Those kind of things I think would be helpful and are probably particularly important for that group.
Wonderful. And I know that this appears to connect to some references that you made in terms of compassion fatigue versus compassion satisfaction. And someone asked if you've seen if empathy has been mentioned as a risk factor for vicarious trauma. And I guess we could look at this as both lenses, a risk factor versus a protective factor. And what's your
That
understanding of that is?
that's a great question. Empathy in particular was not identified either way that I can recall. Kind of an inability or a demand to restrain expression of empathy was identified as a trigger. So I imagine that those feelings might not necessarily directly correlate to experiences of vicarious trauma, but I would imagine if someone is having um, or is inclined to experience empathy strongly towards a client, that might make things a little more difficult if they're in a situation where they're not able to express those feelings effectively. Um, so I think that probably keeping a lid on that and maybe allowing that emotionality to kind of bubble under the surface would be more of a factor than the empathy itself based on the information that I reviewed.
Well, Dr. Cardwell, Maeve, as we reach the top of the hour, thank you so much for what one attendee described as a thoughtful, compassionate, and in tune presentation. I will wrap up here with a particular testimonial that an attendee wanted to add from the audience that says, with the context, I was a partner with Lisa McCann and Lori Perlman at the Traumatic Stress Institute in Connecticut when we evolved the concept of vicarious traumatization. I was so pleased at Dr. Cardwell's thorough review of the original concept. Too often, writers and presenters overlook the original citation when discussing this issue. So thank you for getting to the foundational contributions to this area, and the looking at an optimistic, hopeful view, at least, of the future of how we might address vicarious trauma in individuals that do the work that we often do. So that wraps up this week's Law and Mental Health series. Again, we will be taking 2 weeks of break as the Forensic Postdoctoral Fellowship here at UNM wraps up, and we will be returning on September 2nd, the start of our new fellowship with Drs. Abby Muley and Derek Ruchensky discussing dimensional perspectives of psychopathology assessment in forensic settings. We hope to see you then in September for another great discussion of issues in behavioral health and the law. Until next time.
Thank you.